Okay, so hi guys, my name is Raj, I'm one of the F1s, currently working in gastroenterology, but my first job was hepatopancreatic biliary liver surgery, so I've just been surrounded by the liver for about 8 months now, and my last job was infectious disease, so I've got a very LFT orientated year, so apparently I'm the most qualified to do this talk, which I can't. Oh, can I swear? I don't know. I can swear. That's fine. Okay. Right, okay. So basically, I'm going to go through hepatobiliary disease, which kind of doesn't really cover the pancreas. It's mainly just hepatobiliary disorders. So the aims are quickly liver anatomy, which will take about 10 seconds. Looking in depth at jaundice, gallstones, cirrhosis, liver failure and other liver pathologies. Please don't be bored. I've given you some sweets, so hand them around and have fun, but there is a lot of content, but in terms of how much you're actually going to get asked about this in the exam, it's pretty much almost like maybe 1 or 2 questions, you know? So just think about it that way. So you need quite a lot of breadth of knowledge, but you don't need that much depth, luckily, because you're not biomedical scientists. So just stick to the basics and learn the basic principles, and if you know them, then you'll be fine. I know some of you get worried and stuff around this time, and we were there as well, like, 12 months ago, so I remember how it was. So I'll try and keep it as simple as I can. It's really informal. Please just shout out if you need anything, or you want to ask any questions. Please just shout out. It's fine. Okay, so if you have an obstructive cause here, you can't get your bile down into your bowel. Okay. So once the bile comes into the bowel, you produce, the bacteria change it from bile to urobilinogen. Yeah? So if you can't do that, then you have no urobilinogen in your bowel. The urobilinogen is then absorbed back into the portal system and then goes out into the blood and through your urine. Okay? So although your urine will be dark because you've got hyperbilirubinemia, it'll be conjugated bilirubin. So you'll have bilirubin in your bilirubin in your blood, but there'll be no urobilinogen. So if you dipstick for the urine, you won't see urobilinogen. Does that make sense? Yeah? Okay, good. Right. Okay. Okay, good. So pre-hepatic jaundice, there's only normally 2 different conditions that you really need to know about that could cause this. So I've labelled them there. Okay, so there's hemolysis, or so it depends where you're from. If you're like posh, then it's Gilbert syndrome. But if you're from like Stoke, then it's Gilbert's. I don't know. Sorry. So hemolysis. How do we test for hemolysis? So I'm going to drink. Okay, I'm sorry. I'm thirsty. What are people mushrooming? Tell me. Coombs test, yep. Coombs test, yep. Anything else? So Coombs test will tell you whether it's an antibody-mediated hemolysis. Yep. So it'll show that up. There's another test we can do to see whether there is hemolysis visually. No. Someone's saying it. I can't know what you're saying. Who's saying? Blood film, yeah, blood film, yeah. So on a blood film, you'll be able to see hemolysis visually. So that's basically it. So if you do that test, you'll be able to distinguish between Gilbert syndrome and hemolysis. Yeah. Okay. I'm sorry I spelled conjugation wrong. I apologise. Okay, so there's a case. So there's a 40-year-old woman who's had a hernia operation. During post-op, she's frankly jaundiced. Okay, all bloods are completely normal except for a raised bilirubin. So she's just jaundiced on examination, and she's asking you what's wrong with her. Why is she jaundiced? The clue was in the slide just before. Sorry? Yeah, they were doing last year, weren't they? They gave us like a massive EMQ on bloody LFTs. It was horrific. So just learn this. You'll be fine. Okay, good. Intra-hepatic jaundice. Okay, so almost always a conjugated hyperbilirubinemia. It's only ever unconjugated if you've got severe hepatocyte loss or death. Stools are still dark, but your urine is very dark because you've still got a lot of unconjugated bilirubin, so your urine is very, very dark. Bilirubin is released when you have hepatocellular death. When there's necrosis happening, the bilirubin will be released. So that's why intrahepatic jaundice is caused by anything that causes liver damage. Okay, so that's basically it. So if you cause liver damage, you can get intrahepatic jaundice. Does that make sense? Causes of intrahepatic jaundice: paracetamol overdose, probably the number one cause of acute hepatitis and liver failure. Okay, decompensated cirrhosis, we'll go through that. Infectious hep A, B, C, D, and E. Metabolic diseases, NAFLD and ALD. NAFLD is, does anyone know? Yep, non-alcoholic fatty liver disease. And autoimmune hepatitis, biliary, so PSC and PBC, what's that? Yeah, we'll go through that in a minute. And drugs. Does anyone know which antibiotic especially? Someone saying yeah. No. So someone said colomoxiclab, that's not the right one. Any others? So what's the antibiotic we normally give for someone who's got a cellulitis, like a Staph aureus infection? Fluclox, yeah. Fluclox is really annoying for this fact that it can send people into acute liver failure. So people who are started on Fluclox, since I've started, I haven't seen this done once, but apparently when someone's on flucloxacillin, you're supposed to get LFTs done every 2 weeks. Every patient I've had has been liver anyway, so we've done LFTs every day, so whatever. But yeah. Okay, one sec. Right, okay. So, does that make sense to everyone so far, yeah? Okay. Post-hepatic jaundice is mainly a surgical issue, normally. So it's normally a conjugated bilirubinemia, mainly because of the fact that your bile has managed to trickle down through to a certain point and then is blocked. Yeah? So, because you get the hyperbilirubin can filter through to the kidney, so you get the dark urine. You don't get the urobilinogen, like I said before. You have a high ALP and a high bilirubin, and you have a high GGT as well. Bilirubin is toxic to the hepatocytes. That causes collateral damage, so you get a mildly raised ALT as well. Normally you don't get AST like on your average. Oh yeah. So first line is ultrasound to look for the cause, and you're looking for a dilated CBD or IHD. What are they? Convalda, and what's IHD? Intrahepatic ducts. Yeah. So if you see a dilated CBD and a dilated intrahepatic ducts, then you know that the obstruction is below or somewhere in the level of the common bile duct. If the common bile duct is normal, of a normal caliber, but the intrahepatic ducts are really enlarged, then you know that the blockage is somewhere between the intrahepatic ducts and the start of the common bile duct. Does that make sense, yeah? So you can kind of localize where the problem is. But you kind of tend to see the problem on ultrasound normally anyway. Okay, so I feel like we're going a bit slow, so bear with me, alright? So causes of post-hepatic jaundice. I know, I'm sorry, there's a lot to cover. So any kind of cause of any kind of obstruction, always think intraluminal, intramural, or extramural, and then you'll. I think even for the sake of like your OSCEs, like always try to put your answers into categories, and they like that a lot more. So gallstones, biliary sludge, basically just what it sounds like. And it blocks. It's just like Vaseline basically, and just blocks the ducts and doesn't let anything through. But it can cause exactly the same reaction as gallstones. It can cause acute cholecystitis. It can cause everything else. So don't underestimate sludge. Okay. Intramural tends to be primary sclerosing cholangitis, cholangiocarcinoma, and stricture formation. Do you know what cholangiocarcinoma is? Anyone? It's not specifically CBD. It can happen anywhere inside the biliary epithelium. So it's a biliary epithelial cancer. It's really shit. And I've had loads of patients with it this year, and literally, some of them are like our age, and it's really crap. And it's terminal, and it's horrific. So it's a big cancer of the epithelial cells. You don't tend to notice anything. It doesn't cause any symptoms until you suddenly become jaundiced, and then you've got 6 months. So it's really crap. And there's not many things you can do for it, to be honest. It's got a really bad prognosis, and even with surgical intervention, they don't tend to do well very well post-op. They tend to get a lot of complications, healing problems. Their wounds just come apart. They're full of pus. They get loads of intra-abdominal sepsis and collections. It's not very nice. Cholangiocarcinoma. Do you know what condition puts you at risk of that? Sorry? Yeah, there is. So there's a link. Oh, actually, no, wait. I think that's the other one. No, it's the one. So I'll get back to it in a minute. Extramural. Okay, so PHOP is cancer of the head of the pancreas. A lot of relieved faces there. Okay. Lymphadenopathy. Don't underestimate your lymph nodes. They can cause blockage and can make you very sick, just by their physical pressure of the lymph nodes enlarging. If you've got cancer. Ampullary malignancy, which is an ampulla ovata that we talked about earlier, and even a superior mesenteric artery aneurysm can cause, if it's large enough, and it will constrict the common bile duct at its entry point and then cause jaundice or further. Okay, this is just for your own revision. When you get the lecture slides, you can have a look through and it will help you with your revision a bit. I can't go through it now. What are they? These are gallstones. Okay, so this liver was done by one of the hepatobiliary surgeons at Leeds, called Mr. Ahmed. So thank you to him for letting me use this image. And this P is something I drew on paint. So there you go. So this represents my gallstone. So when you've got gallstones inside the gallbladder, so this is called cholecystolithiasis. Okay, so everything in this thing is pretty self-explanatory if you break the words down. Okay, so you can have asymptomatic gallstones or symptomatic gallstones. This is stage 1 of kind of the disease. So gallstones happens in like a spectrum. Okay, so you start with something almost nothing, very mild, kind of middle grade, and then you can get severe and then life-threatening. That's basically how if you think about it like that, and it basically follows the route of the gallstone as you see it traversing across. Okay, so we'll talk about it. So if you have asymptomatic gallstones, you have no pain, but you have gallstones. Okay, that's probably the case for something around the age of 25 to 30% of everyone over the age of 60. Okay, so lots of people have gallstones and it doesn't cause any problems at all. The moment you start to get pain, it's called biliary colic. Okay, so if this works, I hope it does. So okay, a minute. Biliary colic, so intermittent right upper quadrant pain. Are these slides available to them afterwards? Yeah, okay. See people like furiously writing stuff down. Don't worry, guys. Like, chill out. Seriously. So can cause nausea, vomiting. Normally after a fatty meal, associated with the kind of fat female 40 fertile chav, you know. And normally their vital signs are completely fine. So they've got no clinical systemic features of inflammation. There's nothing. Yeah. So it's just pain and a bit of sickness with your food. Yeah. You can get acalculous biliary colic, which is when, like, biliary sludge, and it can cause exactly the same problems. So this is basically, it's treat exactly the same way we treat gallstones, okay? So you just symptomatically manage them, and you might need to get you might need to get them ultrasound scan to see exactly where the gallstones are, how many there are, how big they are. And then you basically probably need to, if it's causing a lot of pain, it's continuous, they might need a cholecystectomy. So if you have hope to God this works. Yay! Okay, so you have acute cholecystitis. So this P is moving around inside your gallbladder. And look where it's lodged. It's lodged in Hartmann's pouch, okay? That's what this area is called. So this is Hartmann's pouch, which is the neck of the gallbladder. And if the pea or the gallstone is stuck there, it's going to cause impaction. And every time your gallbladder tries to squeeze, it's going to cause the gallbladder basically gets angry, red, hot, swollen. So your rubodol, tumor, calor, whatever they are, yeah. So basically, that happens on a level just around the area of the gallstone, and then eventually over the whole gallbladder. Okay, so the gallbladder becomes edematous and becomes thick-walled and angry, and also releases lots of systemic inflammatory markers, which cause a lot of systemic features. Okay, so we'll talk about that, and then it can move backwards and forwards, in and out, and piss you off. So acute cholecystitis, you can get mildly deranged disease, more continuous right quadrant pain, your vitals will go off, you'll get tachycardia or something, white cells go up, you get SIRS response, CRP goes up, and they're clinically unwell normally, okay? Can cause fevers as well, and what's Murphy's sign? Someone just say it loud and proud. Come on. Yep. Yep. Is that everything? Almost? Sorry? Yeah, so basically, that was basically almost right. Yep, almost perfect. So Murphy's sign is basically, you put your hand in the right quadrant, in the hypochondrium, you tell them to breathe in. If while they're breathing in, they're inspiring, their gallbladder comes and touches your hand, and they get really, really, they get in a lot of pain, suddenly they stop their inspiration, okay? You have to do that on the right and the left, and if the right is more than the left, then it's Murphy's sign positive, and that's important, okay? So yeah, and you get right shoulder tip pain because you can get local inflammation of the peritoneal cavity and the diaphragm, okay? So it may be a calculus again, needs antibiotics, symptomatic management, and they'll need an elective cholecystectomy, normally within 6 weeks, but the evidence is changing now, and a lot of people are saying you need it in your current admission, because people get it again. Why would you normally, why was the old evidence, why would they say that you need to wait 6 weeks? Oh, I can't hear anything. No, not cost. Perfect, yeah. So, if you have acute cholecystitis and you inflame your gallbladder, you basically inflame your entire biliary tree. Everything just gets pissed off and red and hot and swollen. And if you try to operate in those conditions, you're going to have a very high risk, chance of any complications occurring. You're probably going to, you might, obviously experienced hands are going to be very good, but you have a higher risk of cutting something you shouldn't have cut, higher risk of post-operative infection, bleeding, everything else. So normally they used to wait for a bit, wait for everything to calm down. Okay? So you do ultrasound scan. This is a normal gallbladder. This is a gallbladder with a gallstone. Yep. So now we move on to the realms of when the gallstone moves further into the biliary tree. So this is Choledocholithiasis, so basically a stone in the duct. Okay? Right. Now the stone is in the duct. It's in the common bile duct here, yeah? So choledocholithiasis, gallstones in the CHD, common hepatic duct or the common bile duct. 15% of people with gallstones eventually develop stones in the bile duct. It can occur even if the gallbladder is removed, apparently. How would that happen? Anyone know? No. So you kind of, yeah, so the stone is normally, so stones don't just form in the gallbladder, they can form anywhere in the biliary tree. They commonly form in the gallbladder and they become symptomatic, but they also equally sometimes can form smaller ones up in the biliary tree somewhere else. And then they can trickle down. We don't normally tend to hear about those ones because they cause less symptoms. Normally they're so small where they start that they just pass through. but the ones in the gallbladder tend to get stuck where they are, so they get bigger and bigger and then cause more pain. Does that make sense? Yeah? But the ones that are smaller and further up can just filter through normally, so they don't tend to cause that many problems until they're big enough to cause it. Okay, so you get intense right upper quadrant pain, left upper quadrant pain as well sometimes, epigastric pain. Systemic features again, ultrasound them, they may require an MRCP. What's that? What's an MRCP? Cholangiopancreatography, yeah, perfect, good. Why do you think you'd need MRCP? Yeah, good, really good. Sometimes people have bowel in the way, you can't see it, you need a better scan. Sometimes if you want to operate, some surgeons will say, or they want to do another form of intervention we'll talk about in a second, and they want to do something else, they don't like to do it without knowing the full scope of everything that's going on inside the biliary tree. Okay? Right, okay, so we'll move on. So, gallstones stuck in the common bile duct, okay? You get biliary stasis, okay? So you get a cholestatic picture, which eventually leads to hyperbilirubinemia, okay? So the bile level starts to go back up and track up. I'm sorry, my really, really shocking paint things, I'm sorry, okay? Yep, so it tracks up and goes back into the biliary tree, and then you become jaundiced, yep? So ascending cholangitis is the kind of almost the final step of the condition. So basically, over time, your ducts get dilated bigger and bigger and bigger, and then what happens is this germ, or this bug from your bowel, will climb up the biliary tree, past the gallstone, and land itself in this pool of stagnant bile, okay? So what you've basically done is originally there was a flowing river of bile and nothing could really come upstream, and then suddenly you block it, there's a dam in place, and then whatever is downstream just runs up and just starts swimming in all of this shit, okay? Makes you very sick, and they can travel up all the way, and it's called ascending cholangitis, all the way up into the liver, okay? So this is life-threatening, okay? So Charcot's triad, I was going to ask you, but my bloody animation thing hasn't worked, so I'm sorry, okay? So it's right upper quadrant pain, jaundice, fever rigors, and like, I think while I was on liver surgery, I've had about 5 or 6 come in acutely where they're just like this, and they're like, in the middle of the night, and you're like, it just shits you up. So these people look really, really sick, and they are really, really sick, and it's life-threatening, and they could die. So the way you manage that patient is you need to be able to, as an F1, you need to be able to make sure you deal with their symptoms. You're not going to suddenly you're not going to come up with some definitive management plan for them to get rid of a gallstone, okay? You can do something and make a difference on your level by making sure that you give them everything you can at that point of access, at that point of care. So that means, firstly, pain relief, because they're going to be so pissed off with everything. They're going to be in lots and lots of pain. They're going to need analgesia. Sorry, pain, yeah, okay, yeah. Analgesia. Antiparexials. So their rigors mainly come on when they become parexic. So if you give them paracetamol and calm it down, then they become less shaky, which is good. They're going to need antibiotics. They're going to need blood cultures. They're going to need all their bloods. You might need to do, you probably know that they're going to go for an ERCP or something, so you need to make sure you do a clotting, and you make sure that you do, what else you need to do? Oh yeah, a group and save as well, because some endoscopists don't like to do their ERCP if there's no group, or if the blood's in group or save, okay? They'll probably need a cholecystectomy later to stop the problem happening. People are really sick. So, can come up in your slideshow. Like these ones down there. If they were causing this picture, the gallbladder would normally be really shrunken and fibrosed. And if you got a jaundice, firstly in that case it would be painful. But also if it wasn't painful, even if it wasn't painful, your gallbladder would normally be so shrunken and tiny that you wouldn't be able to feel it. Okay? So normally it means there's another cause. So if you can feel your gallbladder, then you have this, okay? Yeah. So, so you said who said pancreas cancer? Someone shout that out, because you, yeah. So, is that always the case? A very loaded question, I appreciate. Is that always the case? What else could cause it? Yes, good. So cholangiocarcinoma of the distal bile duct can cause exactly the same presentation. And actually, I think I remember treating one girl who's 25. She just finished her law degree, and she got cholangiocarcinoma, just came in with painless jaundice, and it was a massive one at the bottom of the bile duct, and they couldn't take it out because it'd gone up and kind of filtered up through a common bile duct into both sides and sat on the hilum of her liver, and it was just like shit. So okay, so this was a slideshow question. Okay. So a lot of people, I think this is so when you start doing your slideshows, you'll start to go through these slides. When we did it, there wasn't these labels on it, so it was like, what is this? And like everyone just thought it was some kind of genitalia, but it's not. It's the pancreas. It's the pancreas, and that's the head of pancreas cancer. That would be in keeping with the theme of this slide. Right, cirrhosis. Okay, so I'm to be honest, I want to do surgery. So cirrhosis is interesting, but I find gallstones very interesting. Okay, so pardon me if I'm slightly less enthusiastic about cirrhosis. Okay, pathological term, it's not a diagnosis. All right, it's like heart failure or a headache. Okay, it doesn't mean anything. It's just a sign. Okay, so normally architectural disruption, fibrosis with fibrous bands. And regenerative nodules. Okay, so the fibrosis and the fibrous bands are important. So the fibrosis, these are the fibrous bands here, okay? And the fibrous bands basically mean that you're causing blockage to some of the blood vessels, right? So as the blood vessels start to block off, and you get less and less blood vessels, your intestines aren't reducing the amount of blood they're giving to the liver, so they're still pumping up blood, but the blood isn't going anywhere, it starts to back up, you get portal hypertension. Yeah? Make sense? Because of all this liver death and all this lack of blood supply, the hepatocytes die, everything else happens, you get regenerative nodules, so slowly bits of the liver start to try and regrow. And obviously with any kind of rapid turnover, there's a risk of hepatocellular carcinoma. Okay? So you get a cancer risk, basically. Chronic damage that's the important. So it's a chronic inflammatory process. So the causes of cirrhosis, anything that chronically damages the liver, so metabolic things, NAFLD, ALD, yawn, autoimmune hepatitis, hepatitis B, C, biliary. I'll go through all these, don't worry. Right? Okay, sorry. Okay, so I want you guys to name some of the signs. Don't make it tedious to shout out, please. Some of the signs of portal hypertension. Spider nevi, caput medusa, Ascites, no. Ascites is a sign of decompensated liver failure. It's not a sign of portal hypertension. Varices. What are these varices you talk of? Oesophageal, that's the most common. There are others. Any others? Hemorrhoids, yeah. Any others? So we're talking about the portosystemic junctions. That's where all of these things are coming from, okay? So anywhere where the portal and the systemic circulation cross over. The other important bit is that you can get varices in the stomach, okay? And they're called cirrhotic portal gastropathy. So it's basically varices, but in your stomach. So these are all signs. Okay, splenomegaly, caput medusa. So what happens is over time, as the blood blood backs up, the spleen starts to enlarge, get larger and larger and larger. And what happens to when the spleen enlarges? What? Does anyone know? Decreased platelets. Yeah, perfect. So decreased platelets is also a sign of chronic liver disease. Yeah. so a decrease in platelets. So the platelets all kind of go into the spleen, and none of them come out. Yeah. So ascites, so you do peritoneal tap, paracentesis to drain it. They give them spironolactone, so they can be diuretic intolerant, diuretic resistant. This is a bit too much, okay, so don't worry, don't write this down, all right? If you start to get a backup of blood and it slows down, the exact same processes occur that if they occurred in your leg, okay? So you start to get like DVTs in the leg. You can get a venous thrombosis in the portal system as well. So you get portal vein thrombosis. But instead of the clots going off somewhere, even blocking the blood to the liver will mean the liver incurs an ischemic injury, which means it increases its risk of going into liver failure. So these are the kind of the tipping point things I'm talking about. Some kind of insult that's going to tip you over the balance of what your liver can cope with. Yeah? Hepatorenal syndrome, does anyone know what that is? If you do, you get a clap. If you don't, then it doesn't matter, whatever. Yep, so renal failure is secondary to liver failure. And normally, if you cure the liver failure, you cure the renal failure, basically. Okay? Esophageal varices, like we talked about. So, long columns, managed with beta blockers, give them regular OGDs to maintain monitoring. You can band them, so this is banding occurring. So these are two threads going down. And then, so this is the varix. And what they basically do is they use a suction system. So they go up to the vein, and then they basically put on the suction, and the vein goes and comes up into the space, into this hole here. Okay? And this thread is basically going around like that. Once the thing is inside, they basically release this button, and it basically just ties a knot around whatever's sucked in, and then just release it, and then it goes back. Okay. Common cause of upper GI bleeds. I'm not going to go into upper GI bleeds. I think that's a separate lecture as far as I remember. Yeah. Okay. Becomes infected. So you give antibiotics. You get rid of encephalopathy. Tend to be because of the fact that when someone starts to go into liver failure, they're able to process their urea very well. You get a very high urea, sometimes because these people have minor GI bleeds that they're not even aware of, and the sudden rush of protein through their bowels means that a lot of protein is suddenly absorbed, and you get a rise in urea levels. Urea means that there's a rise in ammonia levels, but because your liver can't process anything properly, the ammonia levels become toxic and people then get confused. And the ammonia can also cross the blood-brain barrier and then get stuck in the brain and cause a generalized, well, it's very subtle. Like, so the first grade of encephalopathy is literally they just look like they're bored, yeah, and then they get more and more drowsy, and then eventually they can become like fully comatose. So there's different grades, but it happens slowly. And hypoglycemia, like we said, so blood sugar is important. Okay, so inflammation in the liver, hepatitis, not necessarily infective. You get raised LFTs, high AST-ALT, high bilirubin, so your viral serology is essential. You can have autoantibodies that cause autoimmune hepatitis. Do you know what they are? Which antibodies are the causative ones we're talking about? Anyone? No? Okay, so there's three major ones. There's ANA, AMA, and SNA. So there's anti-smooth muscle antibody, anti-mitochondrial antibody, and what's ANA? Forgotten now. Anti-nuclear, yeah, anti-nuclear. Yeah, okay. So hepatitis viruses. So this is viral hepatitis. Remember, it can be caused by other things. So a quick way to think about it is A and E are the acute ones, C is a chronic one, and B is both. Yeah, that's basically it. So A and E, fecal oral route. You eat some dodgy rice, you can get hepatitis A. Probably not here. C is the chronic one. Normally, blood transfusions, sex, IVDs, and B is both. So you can have blood, sex, and everything else in between, perinatally as well. Okay. interestingly, C has a very high rate of chronicity, but B is a very low rate of chronicity. Okay, so you get hepatitis B virus, and then it kind of dies down and becomes less infected over time. But hepatitis C can stay very, very infected over a long period of time. Has a high chronicity, can have it for a while, has lots of effects. And D is actually, it's really bizarre, and like we don't fully understand it yet. But D is, you only get D if you have B, okay? But D is almost a virus of B, if that makes sense. So like hepatitis B is a virus for us, hepatitis D is a virus for hepatitis B. So it's only available in a very, very, very small subset of people who already have hepatitis D and B in their bloodstream. So this is basically not even just the IVDUs, these are like the kind of the elite IVDUs that really, really like to share their needles, okay? So those ones have hepatitis D, and they can only transfer it to other people who have hepatitis, who do have hepatitis, and then they get hepatitis D and B as well. So you don't get hepatitis B and then get hepatitis D, you get both of them at the same time if you're going to get them. Does that make sense, yeah? Yeah? Nods? Yeah? So you can get hepatitis B by itself, or you can get hepatitis B and D, but you'd never get D by itself. Okay? Shoot me now. Okay, that's for your revision. Have fun with that. Okay, so I think there was a question on that as well. I'm really sorry. Okay, it would take me half an hour, and I wouldn't understand anything I say. All right, so you basically, those are things you kind of learn the night before, because you'll remember them about half an hour, then never understand them ever again. Okay, it's the honest truth. All right. Okay, so primary sclerosing cholangitis and primary biliary cirrhosis. So these are the two conditions that you need to be aware of. So primary biliary cirrhosis, so primary sclerosing cholangitis is inflammation and strictures. It's intra and extra hepatic. It's got a strong link with ulcerative colitis, which I think one of you mentioned before. Primary biliary cirrhosis is the other one, and this is intrahepatic only, and it's connected to AMA, that autoantibody, and very high in women. So this is very high in men, this is very high in women. I'm almost going to guarantee you probably get a question on this in your MCQs. So just look at it. If it's a man, it's that. If it's a woman, it's that. And that's your answer straight away, okay? Then you've always got like a weird murky picture that they're linked with some of the stuff. So just try and sift through it. I haven't written all the associated conditions because there's quite a lot. Does anyone know which one of them causes cholangiocarcinoma? So don't quote me, I'm probably wrong, but I think it's this one. So I think if people who have got primary biliary cirrhosis can then also eventually go and get cholangiocarcinoma, it increases the probability of it. Okay, so they both lead to cirrhosis, though, that's important. And you get strictures of the bile duct forming, and they have a risk of hepatocellular carcinoma. Okay? Metabolic diseases, there's probably going to be a question on these. So Wilson's disease is copper accumulation. It's some gene that mutates. You can't excrete it from your body. What sign am I referring to? Yeah, Gallstones, okay? What should you not say in your OSCE? I'm looking for Kaiser-Fleischer rings. Okay, don't say that. Because you won't be able to see it without a slit lamp, so you look like an idiot. Okay. Alpha-1 antitrypsin deficiency. Oh, so one more thing about these people. So these people can basically go through a process where the copper becomes very, very high in their body, and they can have these kind of bouts where they just vomit up loads of copper, and they become, they can go into renal failure and stuff as well. So that can happen. Alpha-1 antitrypsin deficiency. Normally, it's not really their liver that causes the problems. They normally die of their lung problem. So it's normally the emphysema that gets them. Haemochromatosis has cookbook. It's a mutation in the HFE gene. It's got excessive iron absorption. You can't actually get rid of the iron that you absorb. You're fundamentally unable to get rid of the iron. So these people just absorb more than they should. Okay? So you get this weird slate grey appearance. It's called bronzed diabetes. They get diabetic because the iron deposits on the pancreas and they get pancreatitis. So they can get chronic pancreatitis. And this should be a thought that goes through your head for anyone who comes in with chronic pancreatitis and they look a bit tanned. There was a horrific MCQ question on this topic that was just really annoying. And they basically said, they gave you a typical history, oh, this person comes in with a tanned complexion and they've got diabetes, and they're it gives you the whole thing, it just gives you it on a plate. And then you're oh, it's Haemochromatosis, you're getting all jizzy about it. And then you get a look at the actual options and they basically look for what tests would you do to find this out. And then they just give you a list of horrendous iron studies, but things that it was just a horrific study. It was just a horrific question. So I'm sorry. Again. Okay. But you'll all pass and you'll be fine, so don't worry. Okay? That's basically it. Any questions? That is really cheesy, I'm sorry. Okay. Any questions? Really? Stunned silence. Okay. Well, if anyone does have any questions, my email address is there. Feel free to contact me or whatever. I'm always walking around St. James's anyway. Tend to live out now. So if anyone needs anything signing off, or you want, or ski degree or anything, just let me know. I'm mainly in Bexley Wing. Okay. Thanks, guys.